Many of us on occasion have had a very frustrating experience interacting with the healthcare system. This frustration stems not only from the high stress associated with many of these interactions, but also the expense and the lack of efficient coordination between many of the different facets of the system that we're exposed to. The system really ought to work better and more efficiently than it does. There are several innovative companies that are using Web3 and blockchain technologies to improve the quality and reduce the costs of healthcare delivery. Some of them are working on improved scheduling, some on supply chain efficiency, some on credentials and identity, and others on electronic healthcare records. And some are working on how to improve the experience that we all have interacting with the many elements of the healthcare system. One such company is Solve.Care. Welcome to W3B Talks, an ongoing exploration how the Web3 and blockchain is impacting business, government, and society. My name's Doug Heinzman. I'm the Chief Catalyst at the Blockchain Research Institute. In this episode, we're going to revisit the topic of how Web3 and blockchain are improving healthcare. Today, we are joined by Pradeep Goel. Pradeep is the founder and CEO of Solve.Care. With more than 30 years of experience in blockchain, finance, technology, and healthcare, Pradeep has held CEO, COO, CIO, and CTO roles in various insurance, technology, and healthcare companies. He's designed and built some solutions for public programs such as Medicaid eligibility and enrollment, Medicare current claims, children health insurance and welfare programs administration, such as the Supplemental Nutrition Assistance Program, and temporary assistance for needy families. Many others, both in the US and internationally. Pradeep is also deeply involved with the healthcare initiatives on both the Bush and Obama administrations to design and build several public program solutions under the Healthcare Savings Act and Affordable Care Act. I should also mention that Solve.Care was a winner of the 2022 Web3 and Blockchain Transformation Awards. Welcome to the podcast, Pradeep. How are you?
Thank you, Doug. It's a pleasure to be here. And I'm not sure I know this guy you just talked about.
Well, you're being too modest. It's always such a great privilege that I get to talk to people that are really being impactful and working on important projects. I was reading through. I know quite a bit about Solve.Care. I'm quite inspired by the mission that you're on, and I was reading your website, and right off the top and kind of the about, it says Solve.Care is a global healthcare blockchain technology. Using innovative approaches, we tirelessly work to solve the complex problems that plague the healthcare industry around the world. Wow, that's an ambitious windmill to tilt at there. So how did you think through? I mean, you've obviously got a very varied background, but when you were looking around for important problems to solve and kind of came up with the genesis, that kernel of an idea for Solve.Care, how were you looking at the world? How does that process work? And why did you decide to do what you did?
Well, thanks again for having me, Doug. And it's indeed been a journey. So Solve.Care was more of an evolution of 30 years of being in different roles in healthcare and recognizing patterns of challenges that seem to persist despite best efforts. But the way I came to Solve.Care is, when looking at it from three different perspectives. As a parent, I have two children. One is 15, the other is 8. You deal with healthcare issues for your kids, and you experience firsthand the challenges that come into coordinating their care. And nothing excites a parent more than when their kids aren't getting the care that they need. As a public program executive, looking at how the same problem afflicts and affects millions, so when you're talking about healthcare for all the seniors or all the disadvantaged and vulnerable populations, you start to look at it from a macro perspective, and you said, these are really big. These things affect not just you or I, but millions. And the third element of that is the technologist building really big and expensive systems that were supposed to deliver value to the patient, the provider, the payer, the public program administrator, the population of citizens of a country or a state or a city, and realizing that we seem to be going around in circles. So when you bring those three distinct experiences together, the experience of a parent or a patient, the experience of a technologist and the experience of a public program somebody is exposed to and is directly or indirectly responsible for the well-being of millions, things become pretty clear just through repetition. So over the 30 years prior to Solve.Care, I saw the same pattern play out, whether it's a clinical pattern in terms of access to care and other issues, or it's a technological pattern of technology not supporting our stated healthcare mission, or it is an administrative and payment issues that continue to drive cost up without delivering greater value. Those three things intersected in my mind repeatedly to the point where I said, somebody's going to have to do things differently for things to be different. And that was a clear time, a calling to go out and start Solve.Care with indeed a very bold mission, but we believe very attainable one. Once you break it down and really think about it in a very logical way, it is something that can and should be done, and we took it upon ourselves to do it.
Yeah, the thing that really kind of jumps out for me is the lens that you use that is very patient-centric, right? It's that, the problem that the reality is just because of the nature of who we are and how we live and our bodies and, the way that medicine works and the complexity of all the different subsystems of our bodies, that we have to interact with lots of different parts of the healthcare system. And then we've got to deal with, the payment part of the process and, any sort of rules and exceptions and policies. And it's just really complex and painful. And of course, as I kind of said in the introduction, when you're interacting with the healthcare system, you're already dealing with a lot of stress. And so dealing with all of that just is really painful. So, I find it really interesting that that's kind of the lens that you seem to be attacking the problem with through.
So, Doug, that's exactly correct. As you said, it's a complex problem. And it is indeed complex, but it's also a problem, a multidimensional problem. It's complex only because there are multiple and competing interests in healthcare. So let me break it down for you and the audience. Most people think of healthcare in the context of a patient experience. And there you have a set of issues, such as, do I have access to the right care at the right time? So that's accessibility problem. Can I afford to pay for my healthcare? That's my affordability and payment issue. There's a transparency problem as to how this care is going to play out for me, what the care journey is going to look like, who's going to have what information, how will the care journey be coordinated? That's the most commonly talked about problem. And buried in that problem is the data ownership and data sharing, which everybody is quite clear about, that data is not fluid, data is not liquid, data is not moving between parties as it should. So that's one side, but that's just one leg of the healthcare problem, is the consumer experience. Then there is a second leg of this problem, and that is the administrative side of healthcare, which always exists, is universally despised, but is an essential element of healthcare that contributes to and suffers from the same issues, which is administering healthcare is inefficient. The administrator does not have the right information at the right time or the right tools, and most importantly, does not have the right relationships with parties who they are administering. So whether you're an insurance company administering a benefit plan, or you're a government agency administering a public program, as an administrator, you have some serious impediments today that should not exist. Let's leave aside whether we should have a single party insurer, single payer, or a open market insurance. This is not the issue. Even in a single payer, multi-payer model, we're going to have the same issue. So there's the administrative inefficiency problem. So we have a consumer experience problem. We have administrative efficiency problem. And the third problem we have is the IT system problem, in that we have IT systems that were designed to safeguard the data, not to deliver best possible care. So IT systems themselves are impediments to a better care model that we all wish for, question why we don't have, and yet the system simply oppose that kind of a level of openness that is needed. And then if you want to add overall across all that, is a cost and inflation problem that we all have, which is healthcare is getting more and more expensive. But that's more of a effect of the causality. Healthcare cost isn't increasing by itself. It's increasing because of those three underlying issues: patient's role in it, the administrative role in it, the IT system role in it. And of course, if I may add the fourth leg to this problem, which is the provider, the doctor, the hospital, and their ability to deliver efficient care. So if you break it down, healthcare is very complex, but when you break it down, the repeating patterns become clear. That these are the same issues that manifest in US, in Canada, in India, in China. The disease is fundamentally the same, but the symptoms look very different to different people. So what I try to do over the last 30 years of watching, learning, listening, failing and succeeding, but mostly failing and seeing the healthcare turn for the better and recognizing that we are always treating the symptom. We're not treating the root cause. So where Solve.Care comes from is analyzing each of these four legs of healthcare and says, okay, what really needs to happen for consumer choice and consumer affordability to be better? What really needs to happen for administrator to be able to administer programs, which is something we need as a society. We can't do away with it. And what needs to really happen there? What needs to happen for a provider, institution, or individual, the clinical delivery side of healthcare, which is whom we rely upon the most, to be able to deliver better care? And then finally, what kind of IT systems really bind these people together today? And what we are seeing is there's clearly a line that needs to be drawn between before and after in terms of IT systems, because they are the common piece across all of these guys. So that's where Solve.Care comes into and says, you know what? The whole IT paradigm for healthcare is a major source of friction across all these three stakeholders' experience. So let's fix that.
Okay, so the two questions kind of come to me as I listen to you talk through that. One is you kind of talked about these different jurisdictional characteristics. The British national healthcare system is incredibly different than the U.S. system, which is different than the French system, which is different than the Indian system, and they all have various different stressors. So when you kind of look at the system, are you putting forward your solutions into multiple jurisdictions? And if so, how do you make the system adaptable and avoid kind of hard coding in structures that are going to make it non-functional in different geographies? How do you structure your solutions so they can accommodate different jurisdictions?
Yep, and it's not an easy problem indeed. And we've been working on this specifically on that issue for 6 years at Solve.Care. But again, I've been working on this issue in my mind and in various components of this problem over the last 3 decades. But let's come to it very specifically. So let's break it down into the same three key stakeholders: the patient, the provider, and the administrator. Because they're going to be common. Those three entities exist in every healthcare system, regardless of the law, the rules, the payment mechanism, who pays for what. Those three entities always exist. Somebody needs care, somebody needs to deliver that care, and somebody needs to administer and most likely pay for that care. That model is going to be there. Now, having said that, whether you're in US or in Uganda or any other country, from patient perspective, there are fundamental primitives you have to deliver to the patient. They need to have first and foremost choice. They need to have access and choice. If you can't even access a care delivery organization when you need it, there is no healthcare. So from a patient perspective, the number one problem is how do I make something available to them? So therefore, we have built solutions that specifically enable that choice. And depending upon the country, the choice can exist inside a closed network of care providers or open network. That doesn't matter. You define the network in our world based on the jurisdiction that you're in. So first is giving patient the maximum possible choice, either bound to a geography or bound to no geography. The second is giving patient control over their data. And the third part of that is giving patient transparency over cost as much as possible. These are all configurable. These three elements are configurable for each jurisdiction on our platform. So what we do in a simple nutshell is we allow care networks to be published on our platform that serve a patient population in a specific jurisdiction. So you could build a care network for India, or you could build a care network for diabetics in India, or you could build a care network for diabetics in Delhi, not all of India. So these networks can be created quickly, which serve the right patient population based on need or geography or payment ability or age or law, doesn't matter. So this is one side. Then you look at the provider delivery side, and you can similarly engage the right provider population into the right network in saying that I'm going to have this network include all the endocrinologists, because this is a diabetes care network, and I'm going to enroll all my diabetic population of Delhi, and I'm going to have all the ophthalmologists and endocrinologists in the network, because I don't need an oncologist here. So matching the patient and the provider into these ecosystems creates that access and creates that direct relationship, which is what you want in the end for healthcare to work. And the third part of this is the administrator. So however you want to administer the network, whether it's a patient pay, direct pay, patient provider, or it's a third-party pay where patient goes to the doctor and the doctor bills the insurance company or bills the government or bills the family of the patient or bills a community center, that's a third leg of this equation. So bring it all back together. The way we solve the problem, the reason we can say we can address healthcare ills globally is to allow regional networks to be created very quickly where the identifiable eligible patient population can interact with identifiable eligible care provider population inside the rules of payment defined by the payer organization. And you can create that ecosystem for any jurisdiction because it's very flexible patterns. So you can build it for US where every state has its own laws. You can build it for Canada where you have provincial laws. You can build it for India where the laws are more federally controlled. You can build it for emerging markets where there are no such laws and it's a pure market economy. It doesn't matter. It's just a network design. So we allow that to happen. But underlying all that is a new model of infrastructure, a new technology pattern, a new technology platform where these parties can work with each other with a more equitable, more equal relationship than anything that exists today. So it's about enabling these parties to work together, the three of them that I mentioned, the patient, the doctor, and the payer, but then also enforcing equity in the infrastructure. So nobody has information asymmetry advantage over each other. So this is why we believe that you're going to have to solve, we all can expect a completely different healthcare paradigm, which will still be localized to each country or each jurisdiction. It has to be. But the underlying principle will change completely. The underlying principle that I am subservient to the payer or I'm subservient to the hospital has to be replaced with I'm on equal footing with the other two entities. Whoever I am, this triangle has to be rebalanced, and that's what we are doing.
So oh boy. So you've touched on a few kind of really big concepts here that I just want to tease apart. That one of the last things you were talking about, well, actually, let me take a step back. The idea that networks make sense, that if you find a way to compose complementary parts of a system in such a way that there's low friction between the various different piece parts of that composition and improve the quality or reduce the cost or improve the experience and the simplicity of consumption to whoever's consuming the composed good or service. That makes a ton of sense. And that's a lot of the promise of the Web3 era, right? That it's going to allow us to have the tools to readily compose various different, business or service or governmental entities to deliver these composite goods and services to the marketplace in much, much more efficient ways. And a big part of that is what you were just talking about, in such a way that interests are balanced, that there is kind of an implicit, almost adaptive governance that allows the stakeholders to all ensure that there is a reasonable balance between all of their conflicting interests. And that is a huge, huge deal. Now, that kind of takes me down to a few other trains of thought. One of which was, and I was just hoping that maybe you could clarify this for me, because as I said, I think the idea of a network makes a ton of sense. The network that you used as an example was a network of some speciality, right? That you have all the people that do, whatever it is, they're diabetes specialists or they're radiologists or they're whatever. And I can see the value of that kind of network because it ends up being a marketplace, right? It's easier for someone to find someone if they can kind of go to a network and align what they're interested in or what they need or their availability or their geographic location, et cetera. And you can make that market more efficiently. And I suppose you can reduce the friction of transferring records from one to another. You can simplify, payments on the back end, et cetera. But I kind of think of those networks as what you might think of kind of as vertical networks. They're kind of specialty oriented. But earlier in the conversation, we were talking about this patient centricity, which in my mind is more of a horizontal network that says I don't only need my diabetes specialist and my dentist and my radiologist or my, primary healthcare provider, but I need all of those pieces and they all need to work together to provide me as simplified and as unified an experience as possible. Yep. And so that's a different structure of network. And there's different drivers and motivators behind that kind of network. So are you looking at both the horizontal and vertical networks? And if so, how do they differ? And how do you build a system that can address both of those configurations?
That's a great question. And you're absolutely correct that if you take the patient view, and we must, and we do, in that, I don't care about all the networks that exist. I only care about the networks that I need and that I have joined or I plan to join. But I need to have a unified experience across all the networks. I need to have a unified view of all the data across the networks, and I need to understand how these networks interact with me and my data and my needs. So they're not mutually exclusive. In fact, they're both required. So let's take your question then. When you look at the networks that I join as a patient or as a doctor, those can be disease-based or specialty-based. They can be also eligibility-based in that I'm 65 plus and I'm eligible for a public health program in my country, which is designed specifically for my age group, regardless of what diseases I have. So you will have networks that are defined not just by disease or specialty, but also by who's paying for them. So you could have a network run by an insurance company, a network run by your employer, a network run by your church or your community, a network that is run purely on the basis of self-pay. So these networks they must be rethought. You will need to rethink healthcare, not just in the context of how it is organized today, because today these networks are defined by somebody on the basis of typically where you live and what benefit plan you have from government or your employer or what payment ability you have. But if we allow a whole variety of these networks to exist, some of them in your jurisdiction, some may be on a global availability. For example, we'll give examples of that in a minute. So you have this network layer, and think of that as Amazon of healthcare, although that's a very overused analogy, but we're not selling sweaters. We are selling care delivery models. So you would not go to the network marketplace and buy just a prescription. You're buying care. You're saying, look, I'm a diabetic. How do I stay out of trouble? How do I manage my diabetes? So that's a multi-year relationship you're going to form with a network, because the doctors can change, the nurses can change, the guidance can change, but you're going to stay in that network as long as you have diabetes, which is probably for the rest of your life. Or if I have an episode where I fall down and I break my arm, maybe I'm going to be in a network related to physiotherapy but only for 3 months, and then I recover and then I move on. That network is no longer relevant to me. So networks will be organized by need and by payment. and also by where I live. So that's what a network is in our world. It's about the condition, the care and the condition that the care provide based on your age, your location, your benefit plan, your eligibility. So that's one dimension. This is the marketplace dimension, at which you correctly said there has to be a marketplace dimension. And our view is very simple. Healthcare will remain local and regional. You're not going to achieve, even the digital health world, we are all still going to interact with a constrained universe of healthcare for the most part because of geography and because of law. So healthcare networks can be universal. And our view is that in every country, we will expect to see between 5 to 15 networks that will address the needs of that population. But how those networks are designed will vary country by country. But those 15 networks or odd networks per country will cover that country as a whole. But you could also have global networks that cover everybody. So you can imagine networks as much as wide or broad as your imagination permits. But then let's look at
Yeah, go ahead.
The other dimension is the patient experience. So when I join a network, and no matter how many networks I join in my lifetime, when I'm young and healthy, when I'm old, when I'm elderly, when I'm approaching end of my life, these networks will change. But my experience must remain the same. And that dimension of the patient is also equally important. And that's handled in the platform through what we call the Care Wallet. So user experience must be unified and standardized across networks, and all my data should be interoperable across all these networks, which it is and can be with Web3. And the network should be configured very specifically to serve the population that this care team can serve and the payment model that supports it. And then I have a preponderance of networks to choose from. This is how we address healthcare globally. So those two things have to both exist and do exist on our platform.
Okay, so, and correct me if I'm wrong on this, but it seems to me that you're basically saying that if you provide good quality infrastructure, right, the basis of a network, societies do this all the time. They provide road infrastructure and they set up various different rules and policies and electrical grids and kind of enabling infrastructure, that if you set up good quality enabling infrastructure, that networks will naturally and organically, come into existence, and they will adapt themselves to the specific, constraints and capabilities and needs of their particular environment. And I think you're saying that instead of being prescriptive about the structure of a network, you're focusing on the infrastructure that enables networks. Is that
very well
wrong
summarized? It is, but I would add one more element to that. Networks are not going to organically appear. We are helping those networks to appear. We call this process authoring. And we are helping clients, institutions, governments author these networks on our platform. So they have our support, but they can be fully autonomous in creating these networks too. But the reason they are appearing is not because of some higher purpose, but rather they make economic sense. So the driver for these networks, if you look at it from an institutional perspective, whether you are a clinical institution or a administrative institution or a government agency or a community-run organization, whatever entity is currently responsible for coordinating care for a population has an economic interest in running this network because we can do it better, faster, cheaper than their current infrastructure lets them build. For example, if you want me to dwell on that, a little bit further, as an insurance company today, I've been an ex-insurance, I'm a CIO from insurance background. I've also built public health programs. There is a tremendous amount of IT investment we make each year to try to operate our programs, be it the insurance program, be it the public health program, be it the children health insurance program. Every single administrative organization has a complex IT infrastructure. And that's custom built for that program. It's very expensive to maintain. So we replace all that IT overhead by saying, you know what, you don't need any of that. you can run your current program in a much more efficient way on our platform. But further, you can actually get your other stakeholders, patient and doctor, to have a much more engaged experience, because you are rebalancing your relationship with them. You're creating a more equitable operating model for your program that actually works. So it's economic self-interest that drives networks to come out. If you're a hospital, you want to serve your patients who are with you and are with you, and you expect to come into the hospital over the next, in the coming months. You want to do a better job of serving them. So you can build a network around the hospital universe of population of patients. If you are an employer, you can build a network around your employees for their wellness and for their mental health. If you're a government, you can build a network around your city or your state or your country. So networks are appearing because we deliver lower cost, much higher, much more flexibility, and much better stakeholder experience, which is good for business in the end, right? Because healthcare ultimately is paid for by society or by economics.
Right. So that kind of comes to the fundamental question here. The problems that you've been describing and that many of us are very aware of have existed for a very, very long time. And there have been some efforts to building various different kinds of networks. Sometimes they're coordinated by insurance companies, and as you quite rightly point out, they're largely driven by economics, and often they have intentionally have a lot of tension in the system, a lot of conflict in the system that ostensibly is designed to improve the economics of outcomes. So, to be frank, I mean, those problems still exist, and in many ways, the efforts at building various different types of networks haven't really kind of succeeded in a breakout sort of way yet. So, and you kind of pointed at incentivization of why people should behave in a certain way, why they should make the effort, why they should, normalize the way that they communicate with each other, and make sure that within a network, especially if the payments are kind of ultimately going for outcomes and the inputs to that outcome may in fact be composite, we have to figure out how to, divvy up the payments and make sure everyone's interests are aligned. So what's new here? You built Solve.Care based on a new technology platform. Are we looking at a new kind of enabling technology that will allow us to succeed in building functional, efficient networks in ways that we haven't succeeded in the past?
Absolutely. I mean, this is very much a different, and this, again, I refer back to having watched all the networks, the current networks as we know, being built, operated, and automated by various stakeholders. And those always have a common property that the network operator, be it insurance company or Medicare or pharmaceutical company, whoever it is runs in that network, is in a supreme position. They are the godlike entity, and we all must trust and follow their rules. So in that regard, there's a power and information asymmetry. The network aggregates all the data. The network has all the rules. We must follow them, or else we don't get the care we need, which is why patients feel helpless, which is why I, as a parent, feel like I'm in a grind mill and I have no control. Why do we feel that way? We feel that way because we don't have control over data. We don't have control over the process. We don't even have control over who will and will not give care to us. So what needs to change? What needs to change is that the power structure of the network operator and the network participant has to be same, not at this asymmetrical level. So how do we achieve that? We achieve that by creating a very different technology stack first, where the data does not sit in the hands of a godlike entity who will be tempted to or will abuse that information for their own economic advantage. So technologically, every single IT system on the planet today, dozens of which I have personally overseen and built and seen billions spent on those systems, they are all designed to create an asymmetrical relationship between the network host and the network participant. And our platform normalizes that and says, you know what? The network host powers are severely curtailed and the network participant powers are severely enhanced. So this is the power of Web3. Okay, when you bring it back to Web3, it normalizes our relationship with each other. The second thing that this technology stack does, and this is going to be an esoteric concept, I'll explain it. It inverts the IT infrastructure. For example, and what I mean by that is it pushes the logic to be public and secures the data to be private, which is the opposite of every IT system. Let me ask you a question, a rhetorical one, I think. When you join any programs, Facebook, or when you go to a website, Amazon, or you go to your insurance company's website, and you enter some data through a website, you go to a portal, a mobile app, and you do something. What are you doing? You're sending your data, your wish, your service, your payment, your identity, your request to some IT system, right? But do you know what the IT system is going to do with that data? That system, that Facebook engine, that Blue Cross system, do you have any insight as to what that system will do with this information? You have no idea. Why? Because the logic is hidden from you. You have no idea what the system does. All you are doing is hoping and trusting that that entity will not abuse this information and will give you the service you're requesting, such as sell you a sweater or get you an appointment with a doctor. But you have forfeited your data to an invisible logic against which you are hoping a good outcome. So no wonder, very subconsciously, we are always on a losing position here. What if healthcare was built on a platform where that logic that you interact with, the logic behind the firewall where your data is going to be processed, was public? What if all that logic was pre-audited by entities other than the network operator? So you could see what the heck they're going to do with your information before you send it. But what if that information never had to leave you? What if the logic came to you? So in other words, you could keep control of your data and the logic interacted with your data in full view of the data owner. So we have to invert. Why would that change healthcare? Because then there is no asymmetry between the network host and the network participant. The host can't hide the logic, and they can't see your data without your permission and without your control. And you retain control of your data even if you need to get service from them. It'll be like you are a mini insurance company in the sense that you have all the data in your wallet. And if you need to book an appointment, the appointment logic comes to your wallet and interacts with it rather than you sending it over. Why would you care as a patient? You won't care as a patient about this technology inversion, but you would care about the fact that now you are not going to be denied a claim or forced into a physician, a narrow network of physicians, or be asked to make a payment for something that you are not supposed to do. Because then there is the whole society able to audit what happened between a patient like you and a payer like me. There is no way for you to feel like I have no idea what this insurance company is doing with me, because whatever they're doing with you is universally auditable by government, by auditors, by your friends, by your community, by the insurers, the other insurers. So it forces the inversion of power. It gives the consumer unprecedented level of power. Now, why would I, as an insurance company, ever agree to build a network like this? I would do that because it saves me tons and tons of money. I don't have to have the same level of compliance mechanisms and audits, and I don't have to have all this PR telling everybody I'm not evil, please trust me. The trust is built into the system, right? Which is the promise of blockchain. So I am basically proposing, and we have built this and business seems to like it, the model where all network hosting and network participation is open, but the data is never public. But the logic of everything that you're doing is wide open. So there is no way I can be denied care that I am due just because some secret logic in the program or in the system denies it. So those are the bigger goals, right? Why we think that healthcare will become, over time, But to make that transformation, final point, there is an alignment of incentives needed. Either we're going to have law changes slowly and surely, but they will take a while, or we're going to have immediate economic incentives, which is where we are currently seeing the adoption, or we're going to have consumer demanding more transparency, saying, I want this over that. And the combination of the above is why we see healthcare transforming away from this current model we live in, where you and I feel largely helpless. I want to remove that helplessness that we all feel today when we interact with healthcare.
Well, I had two more questions for you. I mean, you actually touched on both of them, but if just very quickly, I wanted to elaborate on them. The first question was, do you think the regulatory environment is flexible enough to adapt to this new reality, or do you think it needs to be, changed in any sort of fundamental ways? Do we need to call up our local representatives and say, we need to table new legislation or build new regulations to allow for this environment to emerge? Let's start with that one, then I'll follow up with the second one.
Yes and yes. The current regulation, there is plenty of room for us to improve the current delivery systems in healthcare without having to alter regulation. And staying with that, we can actually comply with regulation a lot easier, both the network host and the network participant. So there is lots of opportunity in the current regulatory framework to implement better solutions using a fabric like ours, infrastructure like ours. And that's, again, one of the drivers why we are seeing institutions adopt our platform and why communities are migrating are very attracted to our platform. Communities of patients, communities of doctors, because it creates a different economic model, a better, more efficient economic model for them as well. And there's lower risk for all parties, and there is better compliance because there's more transparency and there's more data symmetry. So the answer to that is we don't need to change the law to see significant value in the short run. But we are also quite certain, the second part of your question, the law will evolve and change because we opened up a new model of healthcare, which is good for society. Therefore, law will eventually catch up. And I'll give you two anecdotes for that. One very personal, very humorous and professional. When I was at one of the large institutions, healthcare institutions as a CIO, my chief information security officer, this is in the late 90s, I was an Apple fan, and I said to him, you know what? We currently issue hundreds of these Motorola devices to our employees, and we then program them and we control them. But why don't we just let people bring their own phone and use it, personalized personal phones? And why are we issuing hundreds and hundreds, even thousands of these phones? And he was like, it's about security. I'm never going to let an Apple iPhone into the shop. It's not controllable. It's all black box, this, that, and the other. Fine. Same is true for iPads. Not going to happen. This is regulatory-wise not possible. Then a few months later, our board chairman came to a board meeting with an iPad. And he said to me, I want to use the iPad for all the board materials you send me. I don't want to get that paper 1,000 sheet boulder of a binder you send me every quarter. I want this all in a PDF format on my iPad. Guess what? In about 7 days, all the regulatory issues fell apart. And the next board meeting, every board member had an iPad and all the board materials were on PDF format on their document. And my CSO found a way to be compliant. And that opened up the door to where within 2 to 3 years, we were no longer issuing company phones and everybody had their own device and we learned how to manage it. The same regulatory environment, we had tremendous resistance till the important consumer said, hell no, I want a better solution. So we are creating demand. Our care wallet and our care networks are creating that demand, that pull towards transparency. So that's one way we see the change happening. Make the consumer demand something business will have to respond. The second is make it cheaper for the business to do what they're already doing. They have to do anyway. And third is to lower the risk and improve their ROI so they can do whatever they're doing at a lower cost and much lower risk. So our platform was designed to serve CIOs like me to be able to say, hey, this is a better way of doing what we have to do. And it's also designed to have the consumer say, hey, this is a lot better experience than I have ever had before. And that includes the patient and the doctor. So we have to work on this complex equation, but the underlying principle is it's a new technology paradigm, leveraging blockchain and Web3 in a way that healthcare has often dreamed about, but that nobody has ever had the investment of time and energy that it's needed to pull it all together. That's what Solve.Care is doing.
Okay, well, that's in fact the perfect place to just quickly insert this last question I had, because you've set it up so well. And that is, and just a couple off the top of your head, what are your key predictions? I mean, with all of those things that you just told about, let's say that they're all true, that there's user demand and there's, that the technology will adapt to accommodate people's concerns and all that kind of stuff. What are your predictions about where Web3 is going to be most impactful in healthcare in the next couple of years?
I'd say three things very clearly. First is that Web3 and blockchain today are sometimes seen as solutions looking for a problem. And we have always looked at the healthcare ecosystem as needing reform and restructuring. And blockchain and Web3 are very crucial shifts, better technological shifts that can make the healthcare ecosystem work more equitably. So we believe that companies like Solve.Care, which are looking at more from a top-down view, starting with healthcare, starting with all the regulatory and administrative payment processes and clinical care delivery challenges, we will bring Web3 and blockchain to market. We have brought Web3 and blockchain to market where people don't care about those terminologies per se, but they deeply value what they mean in terms of business and consumer experience. So we predict significant adoption, but not from a tech stack up, but from a business process down, from a user experience down. So this is my view, is that we're going to stop talking about technology stacks in the next 2 years. We're going to be talking about consumer, provider, payer value. And that conversation has already begun. We rarely present those tech stacks as a differentiator. We only talk about what you can do. And I think that's going to accelerate. We're going to shift the conversation from tech stacks to consumer, societal, and business value. The second thing that I see happening is that new payment models in healthcare will emerge. We saw that with COVID, right? People started to ask the question already, why do I have to be bound to my local doctors? Why can't I do teleconsultation? Why can't I do self-diagnostics at home? Why do I need to go to the hospital? So we've already seen a shift in healthcare to open networks. What used to be a geographically, naturally confined local networks of my hospital 5 miles down the road from my house is my natural point of care. We are no longer thinking of that hospital 5 miles down the road as my natural point of care. I have an option of finding a doctor online. I have ask a nurse. I have whatever. So digital health broke the relationship between where I live and where I get my care. But it hasn't really changed the care delivery models fundamentally yet. It's still replicating that narrow networks, geographic networks in the digital world. And I predict in the next 2 to 3 years, maybe more than 2, but less than 5, we're going to see a decoupling of care delivery from your geography, significant decoupling, where you will get care where it is best available and the one you like, not where you're located. So we're going to see a significant percentage of healthcare to move from geographic constraints to best availability, best affordability, and best liking. That's a very good thing for humanity. The third thing that I'm predicting is we're going to see completely different payment models. Today, we have most of healthcare around the world is a third-party payment system, where we see I go to the doctor and the insurance company pays for it or government pays for it. So A goes to B and C pays the bill. We're going to see very different models of collaborative finance. We're going to see models where I can pay in advance to my doctor and get care regardless of what my disease state is. So all these models will become a lot more possible, which will then break all these existing paradigms that we are experiencing. And only new platforms like Solve.Care, and we won't be the only one, but you're going to see a very different technology stack power healthcare than last 70 years. So that tipping point We would have expected that tipping point to come in 10 years, but COVID made it happen in 2. So that's my 3 big predictions for healthcare and Web3.
Well, boy, I'd love to talk for another few hours on those 3 topics. That's really exciting. I think that the industry is going to go through an awful lot of changes the next few years, and thank you for all that you are doing to be part of that solution, to be impactful in helping healthcare work better for all of us. So, well, thank you so much, Pradeep, for sharing your insights about the transitioning healthcare landscape. You can find out more about Solve.Care at Solve.Care. And thank you all for joining us for this episode of W3B Talks. You can find more research on this and many other topics at the blockchainresearchinstitute.org. I'm your host, Doug Heinzman. We hope that you will join us for our next episode of W3B Talks.